Hello, I'm Katachila, and I'm especially happy to moderate this session in my first such event as the chair of the new Davidson Department of Public Health, which became official this month. I know there are many alumni, faculty, and students who have wanted this for a long time and who will be crucial to its success going forward. That it is now here is a reflection of considerable work by many in the Davidson community. Well, the impetus for a public health department at Davidson long preceded the COVID-19 pandemic, and its value will extend beyond it. It has certainly demonstrated the complexity of public health problems that we face locally, nationally, and globally. From the broad scientific effort and skills required to understand the epidemic, the disease, and developing vaccines and medical treatments, to understanding how public health and public policy has served us or hasn't, to addressing the structural inequalities that have shaped how the pandemic has unfolded and who it's most affected. We see how the perspectives and knowledge from a range of disciplines in the liberal arts and a liberal arts education associated with service might contribute. Even for those of us in public health who have been doing this for a long time and have seen the complexities of global pandemics and epidemics, from HIV/AIDS to influenza to Ebola and others, this pandemic has presented special challenges in understanding rapidly evolving information, addressing misinformation, and understanding the public health and broader societal implications of the pandemic as we strive to return to what may be a new normal and learn important lessons with an eye towards our fundamental goal of preventing future public health emergencies. I'm absolutely delighted to welcome you to this session on issues related to COVID-19 vaccines, including the science behind them and discussion of rollout and implementation as we address the challenges of vaccine access and uptake. A few housekeeping notes to begin. The conversation is being broadcast as a Zoom webinar. To start the program, I'm going to ask the questions that were submitted prior to the event. About halfway into the program, we're going to turn to questions from the audience. So if you have something that you'd like to ask the panel, please submit it through the chat function and send it to all panelists. My colleagues who are handling the technical side of today's program will help us prioritize questions asked in the spirit of appreciative inquiry, and we will get to as many as we can. We have a distinguished panel of experts joining us today. Dr. James Crow, Davidson class of 1983, is a physician scientist trained in pediatrics and infectious diseases. He's currently professor of pediatrics and pathology, microbiology, and immunology, and the Ann Scott Correll Chair, Vanderbilt University Medical Center, where he leads the Crow Lab. The Crow Lab has a broad portfolio focusing on viral immunology and antibody sciences with the goal to discover mechanisms of immunity important to discovering new therapeutics and vaccines. And recently it's included work on potentially neutralizing and protective antibodies for COVID-19. Dr. Sally Permar, Davidson class of 1997, is a physician scientist, also trained in pediatrics and infectious diseases. In addition to her medical degree, she has a doctorate in microbiology immunology. She is the chair of the Department of Pediatrics at Weill Cornell Medicine, pediatrician in chief at New York Presbyterian Weill Cornell Medical Center and New York Presbyterian Komansky Children's Hospital, and the Nancy C. Paduano Professor of Pediatrics. Her research focuses on the treatment and prevention of viral infections in newborns, including the development of vaccines to prevent mother-to-child transmission of viruses such as HIV and Zika. Dr. Janelle White is a physician trained in pediatrics as well. She has a master's degree in healthcare management. She is medical director of community health for Atrium Health in Charlotte. And Dr. Dave Wessner is a professor of biology at Davidson College whose research focuses on how viruses cause disease. He has a doctorate in microbiology and molecular genetics, and his postdoctoral work has come in handy lately. It was focused on coronavirus at the Uniformed Services University of the Health Sciences. While he has much notable work and many notable publications, I call your attention to A Cartoon Guide to Biology, which was described in one review as a hilarious romp through chemistry and biology. And with that, I'd like to open with a question to all of the panelists. So I don't know about you, but more friends and distant friends and family have gotten in touch with me to ask me about coronavirus. What are the most common questions you get from your friends and your family about COVID-19 vaccines and vaccination? And how do you respond? And I'll let you just jump in.
Well, I can say for me, as my role, especially, my contribution to the conversation today is as medical director of community health for Atrium Health. A lot of the questions that I get is more about trust. Should we trust this vaccine, particularly in our marginalized, underrepresented minority communities? There's just a lot of distrust and a lot of misinformation that's spreading there. So, how I respond to that is really just directing the individuals to trusted websites and known sources, the CDC and other governmental agencies, where we know that we have information that is valid and that's solid.
Great. Sally?
Yeah, I think initially it was, will you get the vaccine? Which I answered yes, because I believe in the process that these vaccines were put through, and probably the most scrutiny that's ever been placed on vaccines ever, potentially, and the most transparency that we've seen really in vaccine development ever as well. And then now I get the question, will you vaccinate your children? And my answer there is, we're waiting on the data to see how well it works in children, but I have been impressed at how safe and effective these vaccines have been in general. And so likely, yes.
What about you, James?
I think the question of people notice that this was the fastest in history we've ever gone from having a discovery to having vaccines being recommended. And I think back to the trust word that Janelle brought up, that's true for everybody. Can we trust the process? And one of the common questions is, what shortcuts were taken to get here, which is, one consideration. And I think the answer to that is there were not shortcuts. The time was compressed, but all the same stuff was done as would normally be done. And you can measure that by how much money was spent. So you can spend the same amount of money over 10 years, or you can spend it all in 4 months. But the actual steps that would normally be taken were all taken. So I think that's one part of the trust. And then the second, maybe issue around trust, and we've even had to face this within our own institution, our own staff and people, is this research, or is this a real vaccine, like for normal public health? So are we testing things out on people, kind of doing research? And there, in some communities, there is a deep and appropriate mistrust of research processes that have not been done correctly. And so, my answer to that is, this is not research. There is a lot of research going on, but the vaccines that have been released under emergency use authorization have been through all the normal steps. So, we could pivot and talk about research. There's an enormous amount of research, but the vaccines that have been rolled out, this is not a research project. These are real vaccines that have been through the vetting process.
And Dave?
Yeah, I think I've gotten similar questions to the other panelists. And the biggest comment I've heard is, aren't you worried that shortcuts have been taken? And my response generally is that the process has been fast, but I don't think it's been rushed. I think those are two different things. I think the process, as James said, I think the process has gone the way it's supposed to, and we should be thankful that it occurred in a short period of time, but I don't think that means it was rushed in any way.
Thank you very much. So we're going to return to the theme of trust throughout this. I think it's an extremely important one. And you've raised, I've gotten some similar questions as well. I'd like to spend a little bit of time right now having a kind of a lightning round, or a semi-lightning round, to discuss some of the kinds of questions that we're hearing a lot professionally and personally about the vaccines, the science, and how they're being rolled out. So people are understandably concerned about the emergence of new virus variants for a variety of reasons. And in particular, in relation to vaccines, their potential impact on vaccine effectiveness. What is the current thinking about this?
One of the variants occurred in the UK, and the vaccine has made the UK disease rate drop dramatically right in the face of the discovery of the variant. So far, it looks amazingly good. I think on paper it's concerning because of the molecular biology, but the evidence looks really good that the vaccines still work.
Yeah, what we can measure in the laboratory is showing that maybe these new variants are more resistant to the vaccine elicited immunity. But as James said, so far those vaccines are working very well to reduce the rates. And there's a lot more than just what goes on in a test tube with your immune system. And so the message is get your vaccine no matter if there are variants or not.
I think another question that's come up from individuals is the popular press to some extent has sensationalized the appearance of these variants. And the appearance of viral variants is not a surprise. I mean, viruses mutate, variants are going to form. I think sometimes the message from the popular press has been, oh no, there's a variant. And that's not really a surprise. That's not really a big issue.
And we also sort of have to relate it to our flu vaccine. So I, just sort of use that as an example that every year, there are some vaccines as a pediatrician, we vaccinate our children on certain series. Certain vaccines have series that are separated by months. But for a flu vaccine, you get that every season. So I try to sort of, show that as an example, as been mentioned on the call, that, viruses mutate and that's what we see. So not quite sure we would have expected anything different with the coronavirus.
Great. What do we know about whether or how much the vaccines prevent transmission? Sally?
So that has been an area of further research that's going on. So when the original trials were designed, they were specifically designed to measure the ability of the vaccine to prevent disease, COVID disease, that include symptomatic disease as well as hospitalization, even death. And one thing that's so remarkable about the vaccines is they have been 100% effective in preventing death, all of the vaccines that have been tested from COVID. But another measure that we would like to know is, can they actually prevent you from acquiring the virus at all? And do they prevent you from transmitting it to the next person? And that is work that we've seen small pieces of data come out to suggest that they do make a difference in preventing you from getting the virus at all, replicating it in your nose and spreading it to the next person. So stay tuned, watch that space. But I think we have good indications that it will at least reduce that.
Thanks. I think that summarizes the issue nicely. Relatedly, but there's other reasons. Why can't people stop the other sorts of public health mitigation measures, at least in the short and medium term, like social distancing, wearing masks? Janelle, you smiled, so.
Yeah, I can certainly take that. That is a sort of sentiment that we try to tell all of our patients, even at our vaccine clinics, and what we have done to try to make sure that we are sending that consistent message is even at our community roving vaccine clinics, we're still distributing masks. We don't want there to be the thought that we can take our foot off the gas, at our public health mitigation strategies. So despite getting the vaccine, whether you're vaccinated or not, the thought is to continue the public health mitigation factors that have been recommended. We certainly don't want to see the vaccine as the magic bullet, that will allow us to not have to wear our mask and wash our hands and social distance. So certainly that's not the message that we want to be given as a result of our vaccine efforts.
So if someone's had COVID, should they get the vaccine or a vaccine?
Yes, well, I know a lot about this. If you measure the immunity that a person mounts after they've been naturally infected, it's okay. You get a moderate level of immunity. If you compare that to what you would get from flu or other infections, I would say it's adequate, and it would probably keep you from dying. It's not the maximal immunity you can achieve. So when research has been done to take one of the mRNA vaccines and boost people who've been infected even 6 months ago, they have an enormous boost of their immune system, like 1,000-fold. So it's clearly a benefit in terms of the magnitude, the amount, of immune effectors that you have to get boosted. And I think you're going to see recommendations that people should get boosted with one. The response in that setting is so high, you don't need to, is going to be the conclusion, because the response to one vaccine is moderately low, but to getting 2 doses is quite high. You get this boosting effect. And in effect, the natural infection is the first vaccine. So you sort of end up at a 2-dose thing. You either get 2 doses of vaccine or an infection and 1 dose of vaccine. Now the Oxford AstraZeneca vaccine is going to be a single dose, and it's more like an infection, and it actually gives a quite good response. So I think there'll be mix and match, but you probably don't need 2. And so that's going to be the message.
So one thing we've been hearing a lot about in the context of this pandemic is herd immunity. How does it relate to COVID-19 vaccination?
Maybe I'll take that, because one thing that I have pointed out in some of the work that we're doing is herd immunity requires that a certain proportion of your population are immune to the virus that you're trying to stop from circulating. And there are some estimates to how we need to achieve that, maybe something close to 70%, maybe higher, up to 80%. We know with a very infectious virus like measles, you need over 95% to really achieve herd immunity. And so this was a pretty infectious virus, so it may even be higher than that 80% realm. But one population that's not being vaccinated at all right now is children, and they make up almost a quarter of the world's population. And so it just emphasizes that we do need to get the vaccine trials done in children and get these vaccines to children, including our college students, to really achieve herd immunity population-wide.
I think that need to get that, whatever it is, 70, 80% immunity for herd immunity, speaks to the trust issue that Janelle brought up earlier. There was a survey that was conducted by Elon University around the holidays, around late December. And their respondents, I think it was like 50% of them said they would be reluctant to get the vaccine. And again, that was a few months ago. But if we have a situation where 50% of the people, for whatever reason, are reluctant to get the vaccine, we're never getting to that herd immunity status.
Thank you. So we've been talking a lot about the science here, and we're going to talk a little bit about rollout in a moment, but just since people have been bringing up the trials and what they show, we've seen in past pandemics that HIV/AIDS in particular, that the innovation around science, there were many lessons that were carried forward in virology, immunology, with kinds of approvals as well as. So do you see things coming out of the rapidity with which these vaccines were developed and some of the techniques that were used? Sally?
I was nodding. Yes, there will definitely be, innovations that will change our lives forever after this pandemic. And I think a really obvious one is the mRNA technology, which has a reputation of seeming really new, but it actually was not that new. So for at least a decade or so, the mRNA technology has been tested for things like cancer therapy. I know I worked with what was once a small company, now a world-renowned company, Moderna, developing an mRNA vaccine for one of the viruses that I study, which is cytomegalovirus, which is the leading infectious cause of birth defects and brain damage. So that, and they did their first trials with the mRNA vaccine over 3 years ago. So this was not a brand new technology, but something that the timing was exactly right, that enough development had gone on with the mRNA platform that it was ready, it was poised for action when SARS-CoV-2 came around. And this is a vaccine platform that clearly has the advantage of speed. It has your own body make the protein that you need immunity against. rather than having to make it in a big reactor in a laboratory warehouse type of situation. So it really kind of shifts a lot of the work of producing the vaccine to your body's own cells. And so that rapid development of vaccines, I think, is something that we'll see going forward, that it won't necessarily take 10 or more years to make a vaccine for each of the new pathogens that we're working towards, even some of the old pathogens that we've been working towards, like CMV, that this will change. So that's one I can talk about, but I'm sure there are others from the other panelists.
I think that's just sort of the beauty of public health, and the essence of public health is one of those things that we don't necessarily probably as a society pay much attention to until there's an outbreak, so unfortunately all of the work that's being done on a daily basis by thousands of people is just sort of, it's not socialized, and it's not something that's going to hit the media. So again, the groundwork and the framework for the vaccine, as mentioned before, has already been laid and it's been there. It just was, I guess, maybe not relevant or again, just sort of not at the forefront of everyone's mind. So again, I think that's a large part of the messaging, that we need to make sure that we're mindful of when we are talking through vaccine hesitancy or, Operation Warp Speed, or was this rushed through, or how did this happen so fast? So I think it does require some of those reminders. And again, as messengers, we try to sort of make sure that we are explaining this, from a public health standpoint.
Thank you. So you've been demonstrating some techniques to do so, but I want to turn a little bit back to sort of communications and trust building and some issues around what we can learn from this pandemic. So the nature of any public health emergency, particularly one involving a novel pathogen like this, is that we know the science and other key information and the logistics of dealing with it even are changing and evolving. But communicating uncertainty and the best available information is that is changed, and it does change, or even that there have been mistakes, as there always are in a human enterprise, can be confusing to the public and it can exacerbate mistrust. How do you address this challenge, and what strategies do you use in your work to do so, in addition to the ones you've already demonstrated here today?
Well,
yeah, I think it's...
Go ahead.
I was just going to say, I think that's important for me as an educator, especially. Me students have to realize that we're not dealing in black and white situations. Regardless of what we're talking about, it's COVID-19 or some other basic research that's going on. There will be ambiguities. There will be new information coming out, whatever the topic may be. And I think it's important for all science communicators to keep that message in the forefront, that there's not an absolute truth with the capital T when we're talking about scientific advancements.
I'm going to say I've lived through 5 or 6 of these cycles, H5 bird flu and SARS and MERS and chikungunya and Zika and Ebola. And in my lab, we make human monoclonal antibodies, which is another technology. And we've responded to each one of these. And we get dragged into the, we need you on CNN and we need you to talk to this and that. And what I experienced this go around was, this is the first real social media environment where an epidemic happened. And that has its own problems, right? There is so much just difficulty in dealing with how to communicate when social media is around. So does mRNA sterilize you? No. People, please, no. Are there little chips in these things? No, there are not. Does this modify your DNA? No possible way. Like, these kind of crazy ideas are gripping the minds of millions, maybe tens of millions or hundreds of millions of people. And there's no basis in fact. And the way that people gather information, a lot of times there's a cognitive bias. The first thing you hear, it's very difficult to let go of that idea. And this round of epidemic was one of the first where we just have to deal with so much difficult misinformation. And sometimes people intentionally doing this for their own agendas and purposes. And I think that's been very unfortunate. And we're all aware there was also this political overlay that had its own misinformation that was trying to use the pandemic for their, whatever your political purposes were. And so the agencies, got pulled left and right in terms of various political factions trying to service those needs, and we're distracted from what's the bottom line here. So I think it was a little bit of it was a new experience, I would say, because of the social media environment. And we have to rethink that next time.
Yeah, I was going to add that hopefully what it has left the public with is this desire for evidence-based information, and to say when we don't know something, and to say when we do know something. Why is Tony Fauci such a great educator? I think he does that very well. He tells you when we know something, and when we don't know something, he tells you that too. And I think the hydroxychloroquine example, where there was evidence from laboratory studies that maybe that drug worked against the virus. And those of us who were physicians that at the time had nothing to be able to do for all these patients that were filling the hospital, we of course wanted to jump on that potential therapy, being an existing drug. It worked in the laboratory, but the clinical trials had to go forward. They had to be placebo controlled for us to see it didn't work at all. And but to have certain leaders who bought into hydroxychloroquine well before we had any evidence that it truly worked was problematic. And then it sort of fell back that maybe the scientists were all wrong to begin with, when really we were just trying to follow the evidence and the process. So I hope that we'll be left with an appreciation for that evidence has to be there to really make a difference in treatment and prevention.
So we're going to turn to some of our live questions from the audience, and one of them is related to this as well. And I think you've outlined some of the issues for sure, but audience member asked, you say to trust the CDC, but the CDC bent previously to pressure from the previous presidential administration. How can you trust what they say now? And I can also speak a little bit to this issue to say that I spent most of my career in the CDC, and there indeed always political pressures in public health, and in fact has been characterized. They were a bit different in the context of the previous administration, but the commitment to evidence and putting forth evidence-based guidelines and guidance, I trust the scientists that I've known at CDC, and I think we're seeing a proliferation of information. But I do think it's also important to cultivate a critical eye around these things. And I don't know if the panelists want to talk about this as well.
I think we've seen the same political pressure at the CDC in the early 80s with the HIV/AIDS epidemic when that started. There was certainly pressure coming from the administration to sort of squash some studies or some evidence, but the evidence did get out. I think, as you said, Kata, there are good people there doing good work, and that evidence is getting out. It's unfortunate, I think, that the CDC has taken sort of a PR hit during this. But I think, we have to remind people that they've been doing great work for a long time, and they're continuing to do good work.
So we're getting a few questions about prioritization, and particularly where teachers should fall in this. And I'm wondering if this group has some thoughts on the prioritization of teachers.
Well, actually, from my understanding, tomorrow that another phase in our vaccinations will open up, and in our teachers and in our school workers will be eligible to receive the vaccine.
And I think, I am glad I wasn't one of those people that had to, come up with vaccine prioritization, because that was a very challenging job. And obviously there wasn't a lot of federal guidance on this. It was at the time of transition of the administrations, and states had to really come up with it on their own. So I think every state had the best intentions in mind. Of course, and I think many states were aiming to avoid disparities that that had clearly played out with the pandemic itself. Teachers in particular, they absolutely should be frontline workers. I mean, we were, the way that we dealt with this pandemic of keeping restaurants and bars open, but schools closed, was really a travesty for our children. And we're seeing the effects as pediatricians on our children with there's a major mental health crisis for our teens, not enough places to treat them for the severity of the mental health crises they're having, obesity epidemics, unrestrained, just children's fitness in general, and even child maltreatment has gone undetected, and we're seeing more severity of cases when they present and less reporting overall. And that's because we didn't have our kids going to school, being seen by another adult, and really watching out for their well-being. So I am a big advocate for that. We need to get those kids back in school, and vaccinating teachers absolutely has to be part of that. But other work that went forward, again, evidence-based, was showing that schools were actually one of the safest place in terms of transmission, especially for the younger kids that did transmit the virus less often than older children. And then also a lot of work has gone on now to say that some of the biggest risk is the transmission between coworkers in school staff and other adults in the building. So I think the right thing for making sure our hospitals were working as best as they could and prioritizing healthcare workers was a good idea, because in January, even in February, we had so many shortages because of quarantines that we couldn't even operate all the ICU beds that needed to operate, and pediatric doctors had to go serve the adults, which may not be the best plan there. So we needed it in the healthcare facility to again limit the staff shortages, but now is the time for teachers, and now is the time for getting our children back to school.
So you may have said it, but when do we think we'll have the results from the research involving children and vaccines?
So I know that, and sorry, I'm taking this because it's my soapbox. It's bringing the innovation of vaccines to children. Is the Pfizer trial opened first. Well, first of all, Pfizer's already approved down to age 16. And so we need to make sure our 16-year-olds are able to access the vaccine as they come up on the priority list. Pfizer enrolled down to age 12. That data is done. They closed to enrollment. I know because I tried to get my son in when he turned 12. And so they should be reporting the data anytime. Moderna is enrolling now down to 12. We have work that we've done in infant non-human primates to show that the vaccines can work very well in that setting as well. That should be coming out soon. So it is, I think we will start to see some data on the 12-year-olds. I expect approval down to age 12, hopefully before school starts. That may be ambitious, but and the other age groups will follow after that.
So some people have reported feeling poorly with flu-like symptoms, particularly when they get the second dose of the 2-dose series. Can you talk a little bit about what's going on there?
I was going to ask James if he knows.
Well, I got 2 doses of Pfizer vaccine, and I had a migraine for 2 days, and I felt terrible all over, but I couldn't take any time off because we were really busy. So I'm one of the 75% of people who had, mild to moderate side effects from the vaccine. For the frequency of these events, which are pretty aggravating for a lot of people, the serious adverse events are very rare. And so I think, after your day or two of discomfort, most people don't have any problems, even though I think for historically, if we had this type of reaction to a flu vaccine, people wouldn't want to get it. But here we're talking with something that's killed 2.5 million people, 500,000 people in the United States. It's really a death issue that you're thinking about, I think. And so it's a good trade-off. It's worth it. In terms of the mechanism, I think we all want to know more about that. We've been studying some of that, and it's not totally clear. It doesn't seem to be something dangerous, but there are things in the vaccines to which we are exposed before the vaccine. So there's a polyethylene glycol. There's some it's not the vaccine itself. There's stuff that that is used to formulate the vaccine. And it may be that people are just remembering their previous exposures to some of these constituents of the vaccine. And again, they're not dangerous, but they're probably activating things. There's also potentially, a benefit to this. So there's a whole model in immunology of how vaccines work. And if the vaccine, which is mimicking a virus, is too bland, it's just kind of vanilla, and you don't make a very vigorous response for it, it doesn't work very well. So you need some sort of danger signals that something foreign is going on here, and you need to react to it. And you need to bring in the troops and clean up the mess. And in that setting, maybe that's why these vaccines are so fantastic, and they're so much better than any of the others, that we're getting this sort of danger signals around it, and the immune system is all revved up and doing a good job. So to me, that's what I was telling myself when I felt that, like, this means it works. And I do believe that. I mean, I'm not just being facetious. I think we're getting some immune activation as probably a benefit. So, but people should be forewarned, if you're getting a 2-dose vaccine, there's a good chance you're going to have mild to moderate symptoms.
And I think it's worth noting too, these kinds of reactions are not unique to the COVID vaccines. I got the shingles series a couple of years ago. I could barely lift my arm the next day for both the initial shot and the booster shot. So this is not something that we're seeing for the very first time with the COVID vaccines.
Right. It's not the severity. It's sort of the frequency. To have 75% of people having something, it's, these typical vaccines are more like 5, 10, 20%, at the top end. So that's what's unusual.
But I think it is a reason people are going to want to know what the recommendation is going to be if you had COVID. How many doses should you get of the mRNA vaccine, which we think may end up that you only need one. Still waiting kind of on the final results on that.
So what are your thoughts on social gatherings, especially indoors, and where there will be vaccinated and non-vaccinated people in attendance?
Well, so again, I think that goes back to what we were, saying before. I just, we're not at the point where we can discontinue, the social distancing and the mask wearing efforts at this point. We're still in the midst of this pandemic. And again, we have to keep in mind, this is a novel virus. There are really no definitive answers. And again, this is sort of just not the time for us to take our foot off the gas, of these efforts. So again, I would still just recommend following the same guidance that has been presented to us thus far.
I was going to talk about the other respiratory viruses that have been so remarkably low frequency this year, like nothing else we've seen in my lifetime of being a pediatrician. So I wouldn't be surprised if we recommend some of these measures for the long term in group settings, especially in schools. Our hospitals are empty when it comes to kids not having respiratory viruses, putting them, giving them asthma exacerbations and respiratory distress. And so, we're actually kids are healthier this season in some ways. And so I think maybe masks all winter could be an outcome of these interventions we learned were so effective.
But just to remind people, the vocabulary around the phases, 1, 1A, 1B, there was an idea we would escalate them and then de-escalate them. And that was logical, and we will do that. But as Janelle said, we're not to the de-escalation phase because we don't have the herd immunity and our case rates are still high. But as we see it fall, we'll turn our attention back to what were the population numbers, the thresholds that turn those things on, and that'll be the rational basis for turning them off. So we have a framework, and it will be data-driven in the end.
So there are a number of different, of course, vaccine trials going on, vaccine candidates and development, et cetera, et cetera. What do you see as sort of the new novel developments that we'll see in COVID-19 vaccine research and development?
I think one thing that we'll probably see come down the pike, and James can probably address it better than I can, but we've over the last 20 years we've seen 3 different coronavirus outbreaks. We had SARS in 2002, MERS in 2013, and now COVID-19. I think this search, and there's probably going to be more in the future. I think the search for a universal coronavirus vaccine, I think would be a top priority for researchers.
Yeah, I think that's a critical idea of, we have these hype cycles for each organism, and people are just obsessed with it and paranoid, and there's this crisis. And then 6 months later, if you said chikungunya to the average person down the street, they're like, chicken what? I never heard of it. Like 1 million people in 1 year got infected in the Caribbean, and it was in Miami and 38 states, and people will not even remember the name. So there are these cycles of forgetting. And the question is, this one just killed 500,000 people in the United States already. Are we going to do that again? And I would say we want it to go away. We want to forget it. But it's an opportunity to do it differently this time and say, so the emphasis in the research community and in pharma and DOD and so on has been going really fast. Something happens, how fast can we respond? And we just saw it's not going to get faster than what just happened. So vaccines were in trials 60 days later, and we made antibodies that were done in 25 days and handed to partners, and you saw antibodies in trials, in the summer. So it won't get faster. And, so fast is not fast enough. So the only way to be faster than responding quickly is to do it ahead of time, as Dave just said. And that means thinking about like what might happen. And I'm convinced you cannot predict the exact thing that will happen, but we know types of things that have happened. So as Dave said, we know SARS, MERS, SARS-CoV-2 can do it. Are there any other coronaviruses out there? And the answer is, if you go catch bats in Asia and you swab them, there are some very scary viruses in those bats. And that's where these things come from. And so we already know the sequences of coronaviruses that could do the exact same thing again. We know that right now today. And the question is, do we have the political will as a people to tell our legislators, we want to put money, we want to invest our tax dollars and effort in looking forward, rather than saying, I hope this all goes away and I don't want to invest. And so I think of it like fire. This is the best metaphor I can think of. Everybody, knows they should have a fire extinguisher in their house now, because your stove starts burning, you put out the little fire. You could have those little extinguishers and put things out when they're small, or your community can buy fire trucks, in case your whole house burns down, to protect the neighborhood. And we're sort of in the fire truck mentality right now. We do not think ahead and be proactive to put these epidemics out when they're small by being ready ahead of time. So I think we know coronaviruses that have the potential to do this already. This is not a mystery. We know there are flu viruses that can and will do this. We know there are mosquito-borne viruses like yellow fever. Zika has shown that it can do it. Dengue. Dengue is already 400 million people a year. People are forgetting that already happens. So it's sort of, I'm a little ranting here, but it's like, do we have this desire to make it all go away and forget about it, or prepare for next time? If we don't do it this time, then we're never going to do it.
Yeah, I think that cycles of forgetting is such a powerful thing for those of us in public health. And just thinking about that in terms of the lessons that we've learned from access and implementation, what do we need to learn in those terms to both to get to our new normal, our normal in this, and going forward, and also try to avoid again that cycle of forgetting we've seen time and time again?
I can say, just from a general overall health standpoint, that this has just sort of, shown us that if we don't have a healthy baseline population, when we encounter another pandemic, then we unfortunately are going to have, hundreds of thousands of lives lost. So I certainly think that this is a lesson learned for us to put more emphasis on just overall well-being, preventative measures. So outside of, discussing vaccines and coronavirus, I can say that this has been a lesson learned for us as and, for healthcare overall.
Other lessons?
Yeah, the access and the inclusion of disparate populations in research is something that we also weren't prepared for, clearly. But more effort was put there, I would say, than had been in the past, which still wasn't enough. And so that lesson will go forward, that not only do we need to address health disparities in just our underlying health of our populations, access to care, but also access to research, and inclusion in research is another area. We'll have to put our heads together and work harder.
And just, what additional things can we do to make sure to really be focusing on health equity? Any thoughts about that going forward in public health?
I would say decreasing barriers to access of care. And that's something that we have certainly taken a multi-pronged approach in our community immunity for all collaborative and strategy at Atrium Health. And, again, multi-pronged approach is, some of it is hesitancy. And then also some of what we're seeing is just lack of access. The way that the vaccine is accessed automatically sets up barriers. There are many community members who don't know how to navigate the website to sign up to get the vaccine. Some don't feel comfortable, going to the mass vaccination events, or they just cannot access the vaccine. So anything that we can do to eliminate barriers to obtaining care, is something that we need to be mindful of moving forward.
Thanks.
There's that.
Go ahead. Sorry.
There's that old adage: you have to give people what they want, where they want it, when they want it, and I think that holds true for the vaccination rollout now too. I mean, that's having vaccinations at Bojangles Coliseum downtown is great. For anyone in Davidson, I defy you to tell me how you can get there by public transportation from Davidson. Me having more localized distribution events, I think would be a great thing.
Thanks.
Give an anecdote. My wife is a physician and she's volunteered to vaccinate here in Nashville. So she's doing that. And she's had a lot of conversations with the older people about the polio experience. So they said, the last time I remember something like this, I was a kid and I had to line up to get the polio vaccine. And I think there's sort of a historical lesson there that that's the last time we really did this. There was polio and smallpox campaigns where we were trying to eradicate diseases. And it's just so interesting if you read the history of the time. People were demanding the vaccines. They were demanding access to the vaccines. They were cheering for the scientists. They were the March of Dimes, people were putting in their dimes to push the effort along. And there was a national and corporate and various spirits to all work together. And anyway, my wife was mentioning the older citizens here are remembering this is like that. Can we capture some of that sort of global spirit where we're all in this together? And her seniors that she's seeing are noticing that, and we have not had that. And that was the early 60s. If you think how long it's been since there was a common interest to pull together like this. So can we capitalize on that?
Yeah, that solidarity is another thing we need to think about in relation to this. So we're coming to the end of our time, but given our audience, I just wanted to ask one last question about a lot of my students in my introductory classes told me that they took the class because COVID-19 really made them start to be very interested in public health. And what advice would you give to a Davidson student who this pandemic has sort of ignited a kind of interest in this, about how to approach that interest and what to learn? Or
maybe I can start, because I was thinking about how my Davidson experience really put me in this field today. I had the opportunity, I think it was the second class, to go to Mwandi, Zambia, and at that time the HIV was the pandemic, and it was ravishing the sub-Saharan population. And when I got to that very rural town that only recently had lights available to its hospital, I just thought, wow, like what can we do to stop the impact of this pandemic, then the HIV pandemic, on this population? And I thought vaccines was the answer. And so I went into a field of vaccines. And so, so Davidson students didn't have to travel to Mwandi, Zambia to get that same experience today, to say, I want to be part of the solution. I want to be part of, not just the solution, I want to be part of being ready. We were not ready. We were clearly not ready. And so, you know, you can be part of the solution, and really to use this experience. It's something you'll tell your grandchildren about, but also to be able to say, and then I was inspired to go into a field that then would make this different for the next generation. Is it's an exciting time.
I think another thing that students are seeing, and hopefully that we're telling them also, is that, you know, public health is a big field. You can make a difference from a lot of different angles. I mean, there's you know, economic issues that need to be dealt with. There's political issues that have to be dealt with. It's not relegated to, you know, there's a medical perspective and that's it for public health. It's a broad tent.
Yeah, that happened to me. I have a similar story to Sally. I mean, when I was at Davidson, there was this very strong connection with Kenya and a school and program there, and a lot of my classmates went to Kenya. And I ultimately went to the Pacific, Papua New Guinea, you know, Senegal, ended up in Kenya in medical school. And I felt the same way. I'm like, wow, I want to be part of something that makes this better. This could be better. It's like just the dignity of these people. And yet this is different from, you know, what my environment is experiencing. And so I think more capturing the spirit of the mission, like what disturbs you about the world that you want to participate in fixing, and then exactly how you do that becomes sort of a tactical issue. So you have the strategy, like what is the strategy of your life? And the tactical thing for me, I was going to be a doctor in sub-Saharan Africa. I went to med school, and now I don't even see patients at all because I got obsessed with antibodies and immunity, and now I run a lab that looks like a biotech company, and I don't even have time to see patients. So I'm a pediatric infectious disease specialist that doesn't see patients. But for my contribution to improve the health of, my interest was children's health in sub-Saharan Africa. I'm doing it here with molecular biology and immunology, and I didn't anticipate that. I couldn't see that when I was at Davidson. I just knew I wanted to do something, and it moved out. So I think knowing what's the something evolve over time, that's helpful more than the exact discipline that you need to accomplish.
Thank you very much. I think you can see the excitement here that I can start early and carry through. And I've learned a lot today, and I'd really like to thank the panelists again, and thank the audience for some excellent questions. And I hope that we can all have other conversations about public health on the other side of this pandemic. Thank you.